The World Health Organization has issued new guidelines for treating tuberculosis, specifically targeting drug-resistant tuberculosis, DRTB, cases. The guidelines seek to empower healthcare professionals to improve patient care and treatment. The recommendations include 2 new treatment options: a 6-month BPLM regimen for patients with multidrug-resistant or rifampicin-resistant TB, MDR TB, and additional resistance to fluoroquinolones, also called pre-XDR TB. Welcome to the Infectious World channel, where we discuss microbiology and public health topics. Thank you for tuning in. Today, we will be exploring the recent WHO guidelines on management of drug-resistant TB. Without further ado, let's dive into the topic. WHO recommends the following for multidrug-resistant, rifampicin-resistant TB: a 6-month treatment regimen composed of bedaquiline, pritomanid, linezolid, 600 milligrams, and moxifloxacin instead of the 9-month or longer 18-month regimens in MDR TB patients. This regimen is referred to as BPALM for short. Drug susceptibility testing for fluoroquinolones is important in multidrug resistance and rifampicin resistance. However, the WHO advises that waiting for susceptibility results should not delay the initiation of patients on BPALM. If the TB bacillus is resistant to moxifloxacin, then it can be dropped from the regimen, and the patient continues with bedaquiline, pritomanid, and linezolid. Thus, the regimen is referred to as BPL for short. The BPL regimen is suitable for MDR TB patients under the following circumstances: pulmonary TB or any extrapulmonary TB, except for TB affecting the central nervous system, osteoarticular TB, and disseminated miliary TB. The patient is 14 years or older. No known allergy to any of the BPLM component drugs. Susceptibility to bedaquiline, linezolid, delamanid, or pritomanid, or the patient has not been exposed to any of the component drugs for more than 4 weeks. If exposure to the component drugs exceeds 4 weeks, the patient can receive the BPM regimen only if resistance to the specific medicines with such exposure has been definitively ruled out. The treatment is suitable for all individuals regardless of their HIV status. If the patient is a premenopausal woman, she must be willing to use effective contraception. BPLM is not recommended in the following cases: in osteoarticular TB, TB meningitis, and disseminated miliary TB, where there is resistance to bedaquiline, linezolid, delamanid, or pritomanid, and in XDR TB, or when the patient pregnant or breastfeeding. Duration of treatment. Patients with susceptibility to fluoroquinolones can be started on the BPALM regimen for 6 months, 26 weeks. When the patient is on the BPAL regimen, it can be extended to a total of 9 months, 39 weeks. The extension of the BPAL regimen can occur in cases where there is a lack of culture conversion or clinical response, based on the clinical judgment of the treating physician between months 4 and 6. Treatment interruption up to 1 month can be added to the overall treatment duration if there is a need to make up the missed doses. Guidelines for discontinuing and reintroducing treatment in BPAM and BPL regimens. If drug-related toxicity is suspected, the full regimen may be temporarily stopped. After a treatment interruption of no more than 14 consecutive days, or up to a cumulative 4 weeks of non-consecutive treatment interruption, the full regimen can be reintroduced. Any missed doses must be compensated for and added to the treatment duration. For individuals switching from BPLM to BPL, the treatment start date should be the same as when BPLM was initiated, since the patient received 3 effective drugs throughout the entire treatment period. The BPBL treatment regimen is standardized. It should not be modified for best results. If adverse events occur, dose reduction or discontinuation of the component drugs may be necessary. Bedaquiline and pritomanid should not be modified. However, linezolid dose reduction is allowed after the first 9 weeks of treatment. In some cases, linezolid may need to be permanently stopped and a decision made to continue other drugs or start a new treatment to avoid permanent disabilities. If there is a need to stop any component drug of the BPAL regimen because of severe toxicity, these are the factors to keep in mind. If one of the drugs, bedaquiline or pritomanid, needs to be stopped permanently, the entire BPAL regimen should be discontinued. If linezolid is discontinued within the first 9 weeks of treatment, the entire regimen should be stopped. If linezolid is stopped in the later weeks of the treatment, but the total remaining duration of the treatment does not exceed 8 weeks, the remaining drugs can complete the regimen. If moxifloxacin alone is discontinued, the regimen can be continued as the BPAL regimen. This may be a concern for patients receiving BPAL because during single drug disruption, the regimen will consist of only 2 effective drugs. Acquired resistance to the 2 remaining agents can be disastrous. Guidelines for determining BPAL regimen failure and switching to an individualized longer regimen when more than 2 weeks of consecutive treatment interruption of all medicines in the regimen occurs, or when more than 4 weeks of cumulative, non-consecutive treatment interruption of all medicines in the regimen occurs. If a patient has missed a high number of linezolid dosages, extending the BPAL to 9 months should be done with care. Switching to a longer regimen is advised. The 9-month all-oral regimen. WHO suggests the use of the 9-month all-oral regimen instead of the 18-month regimen in patients with MDR TB who do not have fluoroquinolone resistance. The 9-month all-oral regimen comprises bedaquiline, used for 6 months, in combination with levofloxacin or moxifloxacin, ethionamide, ethambutol, isoniazid, high-dose, pyrazinamide, and clofazimine for 4 months, with the possibility of extending to 6 months if there's no sputum conversion at the end of 4 months, followed by levofloxacin or moxifloxacin, clofazimine, ethambutol, and pyrazinamide for 5 months. Ethionamide can be replaced by 2 months of linezolid 600 milligrams. The 9-month all-oral regimen, with either ethionamide or linezolid, may be offered to the following patients with MDR TB, where resistance to at least rifampicin has been confirmed, and resistance to fluoroquinolones has been ruled out. Those with no documented resistance or suspected resistance to bedaquiline, clofazimine, or ethionamide or linezolid. Those with no previous exposure to bedaquiline, fluoroquinolones, clofazimine, ethionamide, or linezolid for more than a month. When prior drug exposure is more than 1 month, this regimen can still be given to patients, provided resistance has been ruled out. It can also be given to those with no extensive or severe TB disease and no severe extrapulmonary TB, and to all people living with or without HIV. Pregnant or breastfeeding women may be eligible for a linezolid-containing regimen, but not the ethionamide-containing regimen. Children and adults with no bacteriologically confirmed TB, but have a clinical and radiological suspicion of MDR TB and a history of contact with an MDR TB patient, these patients may be eligible for this regimen based on the drug resistance profile of the isolate obtained from the most likely index case. Linezolid is associated with the following side effects: bone marrow suppression. It is important to note that the myelosuppression is dose-dependent. Peripheral neuropathy and optic neuritis are also toxicities associated with linezolid. Be that as it may, linezolid is far more effective than ethionamide and helps to maintain a relatively effective regimen in cases of MDR TB, where phenotypic drug susceptibility testing results are still pending to confirm fluoroquinolone susceptibility. The 9-month all-oral regimen containing linezolid instead of ethionamide should be offered wherever possible to patients who are eligible. Patients with the following parameters may receive linezolid: serum hemoglobin above 8 grams per deciliter, neutrophils above 0.75 t-ms, 10 to the power 9 per liter, and platelets above 150 times 10 to the power 9 per liter at the start of treatment, and no evidence of severe peripheral neuropathy or any sign or suspicion of optic neuritis at the start of treatment. The 9-month all-oral regimen is not suitable for the following group of patients: those with severe extrapulmonary MDR TB, such as osteoarticular TB or pericardial TB. Furthermore, the 9-month all-oral regimen should not be used in children less than 15 years of age who have other forms of extrapulmonary disease. The 9-month all-oral regimen is also not suitable where there is high-level INH resistance, that is, in cases where there are mutations in both INA and KG genes. The presence of mutations in both regions, that is, in a promoter and KG genes, suggests that neither isoniazid at a high dose nor ethionamide may be effective. There are two variations of the 9-month all-oral MDR TB regimen recommended by WHO in 2022. The first one is the ethionamide variation, which involves the initiation of bedaquiline, levofloxacin, moxifloxacin, clofazimine, ethionamide, ethiambatol, isoniazid, high dose, and pyrazinamide. All 7 drugs are given for 4 months, with the possibility of extending to 6 months if there is no sputum conversion at the end of the 4th month on treatment. Ethionamide and high-dose isoniazid are dropped after 4 or 6 months, depending on the decision to extend treatment based on smear status at month 4 of treatment. Just to clarify, with regard to quinolones, either moxifloxacin or levofloxacin can be given, not both. This is followed by 5 months of treatment with levofloxacin or moxifloxacin, clofazimine, ethambutol, and pyrazinamide. Bedaquiline is usually given for 6 months but could be extended to 9 months if the initial phase is extended from 4 to 6 months due to a lack of sputum conversion at month 4. The second variation of the 9-month all-oral regimen is the linezolid variation, which involves initiation of bedaquiline, linezolid, levofloxacin or moxifloxacin, clofazimine, ethambutol, isoniazid, high dose, and pyrazinamide. Linezolid is only given for the first 2 months of treatment. After the initial 2 months, the remaining 6 drugs are given for another 2 months, with the possibility of extending by an additional 2 months if there's no sputum conversion. High-dose isoniazid is dropped after 4 or 6 months, depending on the decision to extend treatment based on smear status at month 4 of treatment. This is followed by 5 months of treatment with levofloxacin, moxifloxacin, clofazimine, ethambutol, and pyrazinamide. Bedaquiline is usually given for 6 months but could be extended to 9 months, particularly if the initial phase is extended from 4 to 6 months due to a positive sputum smear result at month 4. Thank you for watching. If you enjoyed this video, please like and subscribe to our channel.